Assalamu alaikum, everyone. This is Safdar Khan, and we welcome you all to our monthly activity. And I think it's getting exciting every time we come together. So this time we are going to do a journal club, and Dr. Simma Pirzada, she is one of the neonatal fellows in Canada. She is gonna start with proceedings with her introduction, and this activity was mentored by Dr. Nasar Rashid. So I'm going to hand over to you, Dr. Simma.
Thank you very much, Dr. Safdar. Assalamu alaikum, everyone. I'm Simma Pirzada. I'm doing my clinical fellowship in McMaster University. This is my first year, and I'm very grateful to all of you to give me this chance to present for my own country something. And I'm very thankful to Dr. Nasir Rashid, who was always there to help me and making it very nice and good presentation for everyone. Get started. I won't do anything with camera again. Okay. So let's start with our top title. It's Caffeine for Apnea and Prevention of Neurodevelopmental Impairment in Preterm Population. It is a very nice systematic review and meta-analysis which was published in 2024 in Journal of Perinatology. And I'm Simma Pirzada, as we discussed, and Dr. Nasir Rashid is my preceptor for this article. So let's start with a clinical scenario which we are dealing in everyday routine. You have received a extreme preterm baby at 26 plus 0 week of gestation, born because of maternal reason via C-section. You did all initial stabilization steps. You did surfactant. You maintain access line. Now baby is very stable and is able to breathe on non-invasive respiratory support. You have asked your junior to load with caffeine with 20 mg per kg. He's asking you, would you go for a higher dose for this gestation, or you will go for 5 mg per kg, or should I also go for 10 mg per kg and check for caffeine blood level? Would that helpful? Would that be a good idea? What would you suggest? Any comment? Okay, so we will keep going and we'll see whosoever can participate in between. I would welcome them. Okay, so let's start with apnea. What is apnea of prematurity? There are numerous definitions. Still, we don't have a single consensus, but mostly we accept that apnea is cessation of breathing for 20 seconds or cessation of breathing for 15 to 20 seconds or less if accompanied by bradycardia or desaturation. Again, bradycardia and desaturations define numerous with differences in a little bit of the numbers, but usually we accept that in this literature review article, which I am going to discuss, they took bradycardia as heart rate dropping less than 100 beats per minute, but it can also be defined as heart rate drop by 30 beats per minute from the baseline heart rate of that infant. And desaturation, we all know that dropping in saturation less than 85 or for 5 seconds or longer duration. So let me just go through a little quickly about what is the control centers for breathing in neonate or premature infant. So there are chemoreceptors and which are located in the brain, that is central part, or they are located in the peripheral system and the aortic root, aortic bodies, and carotid bifurcations or carotid bodies. These peripheral chemoreceptors are actually sensitive to blood oxygen, pH, and carbon dioxide. While the central system, which control breathing, is located in the brainstem, some centers in the pons, but the medulla, ventral and dorsal system, which is sensitive to CSF, pH, and carbon dioxide mainly. And then these sensors, they senses their biochemistry in blood and CSF respectively, and then they give command to brain via glossopharyngeal nerve and vagus nerve to control and regulate breathing in response to respective values. But this system is immature in premature babies, and therefore their response is not robust in response to higher carbon dioxide and drop in oxygen. It's well developed in term infants, but is immature in preterm infants. And then we also know that then the brain, in response to these biochemistry, pH and carbon dioxide, oxygen, give command via vagus via phrenic nerve to diaphragm and intercostal nerves, and then laryngeal reflex is also controlled there. And then also the sleep pattern plays a role in controlling breathing in neonates. So in premature infant, mostly their breathing pattern is rapid eye movement sleep, or we call as active breathing cycles. So in this rapid eye movement sleep, their control and their breathing support is not as regulated as in continuous sleep. So these are few controlling mechanism of breathing in neonates. And then one important thing is their carbon dioxide response is very suppressed as compared to neonatal full-term neonate. Immaturity itself is a risk for apnea. We know that because of enhanced inhibitory reflexes, diminished hypoxic response, and then diminished hypercapnic response, leading to apnea of prematurity. We all know that apnea is common in preterm infant, less than 37 weeks of gestation, but it is almost 50% seen in infants who are born less than 32 weeks of gestation, and birth weight also plays a role. So if infant is less than 1,000 grams, it's almost 100% seen in very low birth weight infants weighing less than 100 grams. Caffeine, we know it's worldwide used as a treatment for apnea of prematurity, which is a naturally occurring methylxanthine, and we use it now because of its safer pharmacological aspects. So caffeine has different, like caffeine can act on multiple systems of our body, muscles, gut, kidneys, brain, everywhere. But my topic of discussion would be only this, which affect the central nervous system while blocking adenosine receptors in brain. So what does caffeine do? It actually blocks adenosine receptors. So there are different adenosine receptor. What I remember from literature, 4 or 6, I do not know exactly, but it mainly affects adenosine receptor A and A2A. What does adenosine do? It keeps you in a sleeping state, in a resting state. So caffeine blocks that and make you more awake and stimulant responsive. And we know that because of its safer index, it's now being preferred because of safe long half-life and safe therapeutic index. And it's been used for many years now. So let's quickly go through the evolution of xanthines. In 1970s, there were some trials done for apnea of prematurity treatment related to theophylline and aminophylline. And then it was a regular standard care in 1980s. In 1990s, there were some trial done for caffeine in apnea of prematurity, and then CAP trial was a robust study after which caffeine became the choice of treatment for apnea of prematurity. And then there were some ongoing studies for long-term outcome of apnea of caffeine on premature babies. So what does CAP trial say? CAP trial says that caffeine has a robust effect on short-term and long-term outcomes, so including apnea, definitely, and then bronchopulmonary dysplasia, patent ductus arteriosus. It does not say anything about intraventricular hemorrhage, death before discharge, or necrotizing enterocolitis, but it shows that there are some benefit of long-term neurodevelopmental outcome if we use caffeine. CAP trial was a robust study and laid the foundation, no doubt, but there were some unanswered questions as well, like optimal duration, dosage, population, when to use for, does it has any effect on extubation and frequency of apnea, and long-term respiratory or cognitive harm still were unanswered. So the study which I'm going to discuss here says that the objective of the study is to assess effectiveness of caffeine in reducing apnea, neurodevelopmental impairment in low versus high dose of caffeine. Methods. This is a systematic review with meta-analysis. with PRISMA and Cochrane guideline. I will explain this later for my junior fellows. Database used Medellin, Imbas, Sinhal, Central, and they included all the studies published up till 2022, and they were all randomized controlled trial. They did not include observational studies, and there was no restriction in language as well. Outcome measures they observe for apnea, BPD, PDA, death, developmental outcome were divided into 4 groups, and I'll explain those groups later. And the risk of bias was assessed by ROB tool to rule out over biases, and certainty were checked by grade approach. So let's see what are these terms for my fellows. Prisma is actually gives you a checklist. So you just check mark. You have included 100, like say 1,000 studies, and then you go which are duplicated study. You exclude those studies, and then you see which study you can get it like as a whole study or just the abstract. You exclude those study, and then you go to the next step. You see if the studies you have with you include matches your inclusion criteria. If yes, you include that. If no, you exclude that. And then there are again checklists to see whether the study has the same population, same intervention, or wrong intervention, then the dosage, methodology. So there is a checklist. So you mark through all those checklists and then you exclude all your studies. At the end, whatever you include should be matched according to your inclusion criteria. And then you go to do systematic review and then meta-analysis. So for my colleagues, systematic review is actually they gather all study, publish on the same question, which we are going to evaluate. And then they collect all study, summarize, and then analyze those results. And meta-analysis is again, could be the part of systematic review or could not be the part of systematic review. But if it is a part of that systematic review, it increases its importance and weightage. It is actually biostatistic analysis of those results. Okay, so what other term I used here were database. So database for Medellin is like PubMed, US-based database where you can find robust studies. Embase is European-based database, and you can find more European studies, and pharmacological studies are broader in that database. Sinhal is actually central index for nursing and midwifery. You can find a lot of articles on that. It also has a good article sources for allied health like occupational therapist, respiratory therapist, and what else we use, pharmacological things. So central is actually a very specialized Cochrane database. You can find all randomized control trial in that study, so you don't miss if you're going to do any systematic review. All randomized control you trial are registered there. You can find there very well. ROBE. So ROBE is actually a tool which is developed by Cochrane. It's again a checklist to see integrity, quality of that study, whether the study is used really trustworthy or not. They check how did you do randomization in that review, how did the blinding of the assessor and data was analyzed properly or there was some integrity issue. What is grade approach? It's actually grade is a mnemonic, which means that grading of recommendation, assessment, development, and evaluation. So it is again, it provides you a structured way to divide your study into high certainty, moderate certainty, low certainty, and very low certainty. It also gives you that the study is solid. Its study is very precise and there are less biases. So this is a PRISMA flowchart. Here in the review article, which we are discussing today, they reviewed and found there were 6,500 studies. And then they removed duplicated study, and then there were almost 3,000 studies. They excluded further studies, and they found there were 166 studies for review. And then according to the PRISMA guidelines, they excluded other studies, including wrong study design, wrong intervention, wrong population, wrong doses. And eventually at the end, they found out of 6,000 studies, there were only 15 studies to be reviewed for this systematic review and meta-analysis. And Cochrane, I just forgot to explain this Cochrane guidelines. So this is actually a standard or gold standard handbook, a handbook to do systematic review and meta-analysis. Dr. Nasir, would you like to participate for any joke or any comment?
Well, I was recommending to Simma that, the best CAP trial that is being done so far was a CAP trial done by Barbara Schmidt. We talk about her a lot. But I wonder that did she bought stocks in Starbucks or Starbucks after that and must be a millionaire now, because based on that study, we are using caffeine a lot. So I'm guessing that she must be now a multimillionaire. So keep going, Dr. Simon.
Okay, thank you. Okay, so in this systematic review, we found that there were 15 studies included, and the number of infants were 33,500 preterm, and they divided into 4 groups. Neonatal period, less than 1 year of age, from 1 year to 5 years was the second group, from 6 years to 11 years, and then 12 years to 19 years was the fourth group. So this is a wholesome result as a whole. They said that out of these 15 randomized control trial, they compared group caffeine versus placebo treatment or no treatment group, and they found there were reduced apnea, reduced BPD, reduced PDA, and possible motor benefit in middle childhood with moderate relative certainty. And then high dose versus low dose group, they again found less apnea, less BPD, but there was some tachycardia, but there was low certainty. If you see relative risk of 2.29. Now, in neurodevelopmental outcome, they found there was no difference in early childhood. In middle childhood, there was decreased motor impairment with relative risk of 0.72. Moderate certainty in adolescent, they did not find much data. Now I will give chance to Aisha to explain this 2 slides for us.
Good morning, everyone. My name is Dr. Aisha Ishtaq, and I am a residency match applicant this year. And currently, I'm rotating with Dr. Nasar Rashid, and he has been entertaining us with his jokes all around.
I have 2 products that I have participated. There is a taster's choice, and there is a double energy. So if you are doing a high dose, use this one. And if you're doing a low dose, you can use this one. Go ahead, finish it.
Thank you, Dr. Ashton. Okay, so Dr. Simma has been mentioning relative risk and confidence interval and all of that. So let's go over what these things are and how do we plot them on a forest plot. So relative risk is the ratio of probability of an outcome in a group that is exposed to a certain factor versus that group which is unexposed. So it's basically a measure of association between the exposure and the outcome. If there is no association between the exposure and the outcome, the relative risk is going to be 0, which is basically the null value for relative risk. If it's more than 1, then there is a positive association between the two. And if it's less than 1, then it is associated with the reduced risk. Now, confidence interval is basically a range of values that is most likely to contain the value for the parameter, which in this case is relative risk. If the confidence interval somehow includes the null value for relative risk, which is 1, it means that it's not statistically significant. The p-value for it is going to be more than 0.05. Next slide. Okay, so a forest plot is basically a graphical representation that we use in meta-analysis in which we plot the relative risk and confidence interval of different studies, and then we sum up all of that effect, and the sum effect is represented by the diamond at the end. So it is basically a graphical representation which is used in meta-analysis to present the estimated effects from individual studies and the overall pooled estimate along with their confidence intervals. It allows a quick visual comparison of the study results and the assessment of consistency. Each row represents a study with the boxes representing the results of the study. The boxes in this case represent the relative risk, and the size of each box correlates with the study weightage in the meta-analysis. Each line represents the confidence interval for the study results. So if your confidence interval is crossing the midline, which includes the null value for relative risk, it means that the study results are not statistically significant. Because one is the null value, and as I explained earlier, if the confidence interval includes 1, it is not statistically significant. And the diamond at the end represents the combined effect of all the studies with the overall confidence interval. Over to you, Dr. Simma. Thank you so much.
Thank you, Aisha, for a great explanation. So let's go on our own forest plot of this study. So there were 2 groups, caffeine versus placebo group or no treatment group. And then we'll do a review with caffeine, low dose or high dose group. So apnea is a dichotomous failure measure. We see that there is diamond. So the pool effect were 0.59, which is moderate certainty. In bronchopulmonary dysplasia, pool effect were 0.77, again moderate certainty. And then patent ductus arteriosus was also 0.67, which is again moderate certainty. If we compare tachycardia in caffeine versus placebo group, so we see the pool results were 1.5. So there were some evidence, but not that much significant. We remember that Aisha told us 1 or more than 1, so it is more than 1, so low certainty. And then interventricular hemorrhage, again, there were no robust data was available, and we cannot comment on that. And then death before primary discharge was also there was low certainty, and there were not much study available to evaluate that result as well. While the other group, caffeine in placebo versus no treatment for apnea continuous measure, we found that the mean difference was 0.2 and a small absolute reduction in continuous measure of apnea, which is again very low certainty. Intermittent hypoxemia, there were differences in definition, and pool results were not really reliable in that outcome as well. And there were not much data for retinopathy of prematurity and duration. Yeah, and duration of mechanical ventilation. Few studies says that there were a reduction in number of days for ventilation in the group with caffeine, but it was not like very robust data available, so we can say that. While growth velocity, there was only a few studies said that there was some reduction in growth in the group who were using caffeine. And in time to establish oral P, there were only a few studies, so we cannot have a robust result as well for that outcome as well. So in overall, this is the largest study, which included all the randomized control trial. Which is the strength of this study. They used all standardized parameter, PRISMA guidelines, Cochrane, and then grade, and they registered their abstract before in Prospero. Considered multiple developmental epochs, so 4 groups to review for neurodevelopmental outcome. Limitations, we still could not find a result. There were many small studies. There were heterogeneity in definition of apnea. Few long-term outcomes, only few studies. We still don't have answers, and there was no optimal dose mentioned. So these were the limitation of this systematic review. We know that now that caffeine reduces BPD and PDA with moderate certainty, likely safe and beneficial in short-term outcome, but there is still some evidence for long-term neurodevelopmental outcome, but not that we can rely on that. High dose caffeine may reduce BPD with some risk of tachycardia, which is manageable, and we do not find it very significant. It was with low relative risk. So still, we need to think about and work on what is the optimal dose for caffeine, standard versus high dose. Do short-term benefit outweigh uncertain long-term effect? We do not know about that. How should we monitor for the side effects? We know one is tachycardia. There must be others as well. We do not know anything about that. Should caffeine be extended to late-term preterm with intermittent hypoxemia or apnea? So we need to review our local NICU guidelines, keep an eye on new emerging trial and studies, and promote follow-up studies to that examine safety and effectiveness beyond infancy. Thank you. If Dr. Nasir, do you want to have some concluding remarks or any question from anybody?
My conclusion is just like you did a wonderful job. I think you summarized everything very well. Aisha was very good in explaining the basics of these complex diagrams, which sometimes can be overwhelming. But I think overall, you did a very wonderful job. I think the only thing I would like to ask you, Dr. Simma, is that if you have to give just one line conclusion based on after reading all this, that would you change the way you're doing? First of all, tell us what you are doing, and then B, are you going to change the way you are managing your babies in your unit? Thank you.
Okay. So I've worked in 2 different setups here in Canada. In Sinai, they just fixed with single 1 low dose of caffeine. That is after loading dose 5 mg per kg, and they do not go for top-up doses. But their practice, there was no difference, and there are some other things which we can rule out if there is persistent apnea in infant. But here in McMaster, they go for higher dose, they go for top-up dose. And I have seen tachycardia here. And honestly, in my personal observation, I could not see much difference after giving top-up doses. Even we have loaded with those again in caffeine and apnea of prematurity. And then we backed up and there was no response of adding extra dose. So my personal experience was not in favor of repeating dose or higher dose, but everyone has their own opinion.
Thank you, Dr. Simma. Can you please take us back to your slides and explain a bit more between the 2 doses, the low dose and the high dose? You explained very well between the caffeine and no caffeine. Your data slides, the forest plots, yes. The one on the right side, yes.
Yeah. So if you see here, the pool data, the relative index was 1, which is, as you remember, it's just at the borderline. If it's 1, less than 1, it's significant. So it says that there was no significant difference for apnea if you use higher.
First, can you tell us what was low dose and what was high dose?
Oh yeah, so low dose was 5 mg per kg, which is a regular dose, and high dose was 10 mg per kg per dose.
That is the loading dose.
The loading dose was 20 mg per kg.
In both cases?
In both cases, yeah.
Yeah, so the difference was only in the maintenance dose?
In the maintenance dose, yes.
Okay.
And then in this group, again, if you see the relative index was again 0.2, which is significant in case of intermittent hypoxemia. And then in retinopathy of prematurity, there were no robust studies, so I cannot rely on this minimum studies. And then ventilation, actually, I cannot see this slide. Yeah, here. So if you see the pool result, it's 0.54, so it is moderate certainty for duration of ventilation. But as you review the whole article, they do not find many studies supporting this statement.
Safdar, can I ask some questions?
Yes, please go ahead.
Yes, Dr.
Sajjad bhai, yeah.
Please, go ahead.
Thank you very much, Simma. It's a very nice presentation. I have 2-3 basic questions first, because I did a lot on caffeine and about the sensitivity of carbon dioxide and all those stuff. The first basic question, why we choose this article?
So we wanted to see if there is a robust effect of high dose of caffeine and we need to use that thing. Would it be beneficial or not? It's a nice topic of debate and could benefit our infants.
Okay.
This was the most recent meta-analysis we had on a medicine which we use on daily basis.
Okay, so that's so. Nasir asked you this thing, that what is your conclusion? I mean, to me, this is a recent meta-analysis, but these are not a very good systematic review, not a very good meta-analysis. It will not give you any new information. Any new information, you got it from that?
To be very honest, no.
Okay. And the other thing is that caffeine versus a placebo, and they said very low certainty. Okay,
Yeah.
on the basis of what? Look at their meta-analysis, look at their study selection. It's not that appropriate. Okay. Why they didn't, and the other question, why they didn't include CAP trial in their meta-analysis?
I think
They
Junaid, cap trial is there.
there.
I
Yeah.
didn't see in the CAP trial any,
Shimon, there
Yep,
were
cap trial is there. Yeah.
where?
um,
I don't think so. There is a
No.
CAP trial because long back, Nasir, if you remember that
kept trial,
we
Dr.
yeah,
Jain.
I am coming to that. Nasir, we remember long back when this article came, we discussed in Naveed groups. But anyway, you see, I'm talking about the for apnea. Caffeine is primary for the apnea of prematurity. In that one, the CAP trial is not included. What is the reason for that? That's why I'm saying at that time, it is a year ago, Nasir, remember, or maybe Safdar also, when we have a chat on this article on some one other WhatsApp group. This is the same thing with that. Now look at the caffeine versus placebo apnea. Only apnea. Look at the heterogeneity in the only 4 studies, 5 studies they have, and heterogeneity is 78%. So it's a very bad meta-analysis, okay? Because all those studies are not very, not homogeneous. This is very heterogeneous. So my point is that caffeine for apnea of prematurity for all my young and enthusiastic fellow, that is a standard of care, okay? You cannot say that, oh, this is a low certainty apnea. I will think that I will start caffeine or not. No, it is, and the caffeine for apnea of prematurity is a very robust evidence. Not only this, but also this. If you heard the new trials called MOCA trials and the other thing which actually try to prolong the treatment of caffeine even after the discharge. Anyway, I'm not going to discuss that, but I think these articles are good for reading, but not to the implication on clinical implication of these articles to me are very, 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 very poor. I mean, just we can
Yeah,
say that
Dr.
like,
Jain, I have a question.
yeah.
If what I can read, what is my understanding from the forest plot and this study, so they say that there is robust effect on apnea in caffeine group versus no treatment group. If you see
No,
this
but
there,
in your slide you said is a very low certainty.
in high dose versus low dose.
No, and go back to your slides, your slide and your results here.
Oh yeah,
Caffeine
sorry.
versus
Yeah,
yeah. So it's
it's
very low certainty. It's not. It's a very high certainty. And I will tell you one
0.59.
thing. I will tell you about the high dose also. If Safdar give me or Nasir give me 2 minutes extra.
You have
The
5
high
minutes.
dose.
Doctor, you
Nasir,
have
thank
five
you.
minutes.
You
Okay,
have
Nasir, thank you very
you
much.
have all the
So
time, Dr. Junaid.
no, the high dose, okay, when you use high dose, the standard is 5 to 10 milligram per kg, as you said very rightly. It depends on the babies, okay? If you see the sensitivity, the most sensitive thing to us, all of us, to breathe is carbon dioxide. The
Yeah.
sensitivity of the carbon dioxide in all premature babies are different. So the dosage you will adjust clinically. We cannot say that, okay, high doses has no effect. No, we cannot say that. Okay, again, look at the heterogeneity in apnea continuous in high versus low dose is 87%. So I rejected these meta-analysis right away. We discuss all these things, Nasir, remember, and Safdar maybe. So that's why high dose depend on the clinical implication of the high dose. It depend on the baby. Let's say 25 weeker. Not all the 25 weekers has the same sensitivity for carbon dioxide as you explain in your beautiful picture of physiology. I love physiology when you did a great job to explaining the physiology. So it's not the same as all the 25 weeker or all the 26 weekers. So sometimes you adjust the dose accordingly. and Nasir is very enthusiastic today. I know to start with the cumulative dose, discussion, but it is we will come later on. So the high dose has impact, okay, and yes, it can cause tachycardia, it can cause this thing, but it has its impact on the babies which need it. So this is the my explanation of these things. But I think these meta-analysis has to be reassessed and somebody, some researchers should do it again, because those studies which they included are those studies which are very heterogeneous and they are totally different populations. So we cannot say that 32 weeker you start caffeine. I don't know if it is but we started 32 weeker, 31 weeker below automatically. Is the
Yes.
same effect, which is 26 weekers. So that's how we have to look into the population. Sorry, Safdar, sorry, Nasir and Sajjad bhai, I took too much time.
No, it's okay.
No, no.
Yeah,
Nasir,
Simon, yes, Simon, can you please go back to the same forest plot again? I think if you look on the caffeine versus no caffeine,
Yeah.
the effect is statistically quite significant.
Yeah, it is.
All the diamonds are on one side and just below the null line.
Yeah.
No,
And
Sajjad bhai, it is touching the line. It is not
yes,
significant. It
no,
is
it's
touching
not
the
touching the line. No.
It is touching the line. Look at the
Sorry.
green diamond up there. It is touching the
So
line.
no,
And
sorry. I'm
I know
talking
the
about the one
Zhao
on the.
study. The
Dr.
Zhao
Sorry,
study has no
Dr.
difference.
Junaid, let me
sorry, Junaid.
interject real quickly. Let's Dr. Sajjad finish and
Okay.
then we
Yeah,
can.
if you look on the ones, caffeine versus placebo / no treatment on the left side.
Yeah.
Okay. Yes, yes. And all these three, look, the diamond is below the null line.
Yeah.
And in all these three, the effect is statistically quite significant. You see the p-value given down there as well. So this is very significant effect.
You
And
are
having
mixing.
said that, just to say that the study has no value because it has no message, no, it has a message. And the message is that whatever we are doing right now is as per the current state of knowledge is correct. So it's updating our status and updating our knowledge. So I don't think the juniors should go back with the idea that this kind of study is not to be worth discussion. It
No,
has a
it is.
value in it. I mean, negative finding is also a very good finding.
It is what
So
this
we are
is.
looking
Dr.
for.
Sajjad, you are mixing two things. Caffeine
Yes.
versus placebo. It is
Yeah.
significant, it's showing. But in the result,
Yes.
can I complete? In the result, they put low certainty. Why, if you're, and the thing is that, what is the meaning of that? On top of that, look at the heterogeneities of the studies. This is a very important point to validate the meta-analysis.
So
And
what
I am
level of
talking about high versus
sorry,
low dose caffeine.
Opa,
On the right
speaking.
side, can I explain? All the bars and this thing is touching the bar. In fact, this is not, because the high dose, clinically impact of high dose caffeine is very significant on the babies. And there are many studies by Eric Ackenbold, Barbara Schmidt, including her husband, what's his name, Harish Kirpalani. So that's my whole point, that this type of meta-analysis, I don't want to give anybody a message, that the message they are giving, that high dose have no effect. No, it is not, because your meta-analysis is wrong. You have selected the studies which are not heterogeneous or homogeneous. They are heterogeneous. It's 87% I squared there. We discuss all these things
I
last
think
week.
if we put the
Sorry,
truth,
Dr.
sorry.
Sajjad, before you say anything, let me just really quickly comment on something. The first thing is that, Dr. Simon, what a wonderful job you have done. I think this
Sure, yeah.
important discussion, you did an excellent job, and also Dr. Aisha. I think the discussion which we were having, I mean, this is the purpose of Journal Club. I mean, we may end up concluding that this study is not at the level where we initially thought. That it's fine. But I think the purpose of Journal Club is to bring this discussion and have a critical analysis. I think going back to the point where Dr. Junaid raised and Dr. Sajjad, I think picking this study, I think it qualifies to pick this study because this is the recent study and this at least an attempt, let me emphasize, an attempt to find if there is a difference. So that's why we choose those studies. Now, part of Journal Club is you see which study is actually has more solid evidence as which goes along with Dr. Junaid's point. So I'm bringing this point that we can off the record discuss, how I just don't want this on the record because all this is going to go online to actually say this is, bad study or something, that sort of words. But I think the point of bringing this study in this journal club was because this is the most recent meta-analysis, and that's why I think we are discussing it.
That's fine.
Sorry, Dr. Sajjad, you wanted to say
No,
something?
yeah,
and
I
then
think
Dr.
before I
Junaid.
go, I think Dr. Evernos Al-Hadi wants to have a point, and then Dr. Aisha Ishtihaq and Professor Haq is also raising his hand. So let's give them a chance. So Dr. Avranos, if I'm spelling the
Yes,
right spell.
thank you. Yes, thank you, Dr. Sajid, for giving me a chance to speak. First of all, congratulations to the whole team for presenting this meta-analysis. The only point that I want to include or say is that most of the time when we do meta-analysis, it's not to like prove if a theory is right or wrong. You just put out on a theory and just see if like what data is available and what that data says. So right now, I feel like a study should not be named as good or bad. It's just bringing up a point. And that's it from my side. And congratulations to the team again.
Thank you very
you.
much. I think that was
Dr.
good.
Khalid Haq, please.
Assalamu alaikum, Dr. Pirzada. That's a wonderful presentation. Thank you so much. Just one point about meta-analysis and the forest plot which you have shown. You have very rightly indicated the unity line of 1, the confidence intervals, the size of the box, and the relative risk. But one of the most important things which people tend to forget is the heterogeneity. If the heterogeneity is very high, that box, people look at the line and the box and the diamond, but forget the heterogeneity. If you have a high heterogeneity, that particular graph becomes very much of low value. So always please look at the heterogeneity. If the heterogeneity is high, then perhaps one should reconsider what one is saying. All right, that's all. Thank you very much.
Thank you.
Thank you.
And sorry, can I ask Dr. Haq, what is the minimum level of heterogeneity is acceptable?
Well,
30%?
I don't know what is, but what is important, the less the heterogeneity, the better.
Yes.
And in fact, most of the meta-analysis, you would see the triangle, which shows the closer the triangle, the closer each study within the triangle, that is the much better heterogeneity. And most meta-analysis, Dr. Pirzada would have read that, would show you the triangle which you look at for the heterogeneity triangle.
Thank you, Professor Haq. Thank you.
I'm in my understanding, Dr. Sajjad, I think if it's less than 50%, that is usually people start believing a little bit, being a good study.
But generally, less than 30% is very good.
Yeah, that is
30%,
actually.
yeah, 30% and less is the heterogeneity. It should be. I squared should be less than 30% to believe on. Because see, Dr. Sajjad, don't take me wrong. Look at the whole meta-analysis. Look here. On the right side, second graph, high versus low dose caffeine. The effect is very, very, they are robust effect. And the I square is 0%. So you believe on this meta-analysis or so there is, and whoever said awareness, sorry, doctor, I cannot pronounce your name. There is such thing called meta-analysis is good or bad. That's why my whole point I want to tell everybody that meta-analysis can be garbage or can be very good. That's the whole point I want to say according to the what
No.
that's you see the biggest mistake they did that in apnea they didn't include the Barbara Schmidt study, which is the main study caffeine for apnea of trial. They put it on bronchopulmonary dysplasia, but not on the caffeine versus placebo treatment. That's
Dr.
how.
Dr.
So, Dr.
Junaid,
Junaid, I would argue otherwise because
Yeah.
I feel like they just put on a theory. It can
Yeah.
be right, it can be wrong. There are clinical trials which have failed. So you cannot say that a research is garbage. They just did what they they took a theory and then they proved it
No,
if it was
Avarnas,
right or
no, it's not like that. They made a conclusion. I just want that the people shouldn't take a wrong conclusion. They make a conclusion. If you go into this thing, which Simma also put in their slide, that the apnea is very low certainty. The people think twice, why we are giving the caffeine? Then they put it that this moderate certainty for BPD and PDA. What they are talking about? If you read
sorry.
whole this thing, it looks like to me they are just trying to prove something which they cannot. That's the whole. I think get it from this
So, Dr.
meta-analysis.
Junaid, that was the whole point. They just put out a null hypothesis, and either that can be proven right or wrong. It doesn't matter if it's like proven right or wrong. It was just a study that was done, and the result showed certain
If they
results.
didn't put the
It
conclusion,
doesn't
then
have
it's
to be
fine.
like,
No, if
if
they
we
didn't
go
put
by
the
this rule, I feel like if we go by this rule, we will never do like something
No,
new.
we will do. We will do. There are very good meta-analysis. Read the therapeutic hypothermia meta-analysis. Read the meta-analysis on the PDA or PDA treatment or not. There are many. I can give you the example.
Dr. Junaid,
E-
can I comment on I respectfully disagree to some extent and agree with Dr. Avarno's point,
Sure.
and I will explain it. Let me just give me like a minute or two. I think when a researcher picks up studies, he picks up whatever is published. Okay, those studies may have variability, like they may not reconcile with each other. That is how you create heterogeneity. Now, in investigator's mind, it's not in his control how the studies are. He is just taking all the studies together. And if they have heterogeneity among themselves, they don't talk to each other, those studies, and it ends up being high heterogeneity. So the researcher or investigator's point is not that he has this intention to actually have high heterogeneity or low. It's not in their control. It's the studies which end up being designed differently, which creates all that. So that is why I think her point is that the investigator in this case, they try to generate an evidence compiling all the studies, then they realize, and to your point, which I agree with that, the study has high heterogeneity, you wouldn't probably pay more attention to it, but they try to see if there was actually commonality and we can end up with a good evidence. This was the intention of investigator, I feel here, if I'm not wrong.
No,
I'm just
I
you are
agree
right.
with
One
you,
of
The-
the
Dr.
last
Safdar,
thing
yes.
that I want to also include is that research is never only about good research or something that you want to put out and if the research proves it. Sometimes good research is also proving that this treatment doesn't work. So the scientific community and like the pediatrician and the doctors and the physician knows that what we have already is the best treatment. So that's like the last point I wanted to
I think
include.
that was the message we got from this study. I think the last sentence you have said. That's exactly what we got from this. I think Dr. Aisha is waiting for quite some time to raise her question. Dr. Aisha Ishtiaq.
Go ahead.
Hello, everyone.
Yes,
Okay, so
yes, please.
I actually agree with whatever you guys are saying. Like everyone's opinion is quite valid, but I also agree with what Dr. Junaid said because I just looked up the Barbara study and it compares caffeine versus placebo and the outcome is apnea. So it should have been included in the in this meta-analysis. Like it is like one of the earliest trials on this. It should have been included in the apnea one.
I'm not sure, did the authors give any reason of not including in this meta-analysis? Maybe Dr. Nasar Rashid or Dr. Simma can tell us.
No, they didn't give
Because the
any answer.
I think the apnea is already the proven effect of caffeine, but the question
Can
is
I say
long
something,
term.
Dr. Sajad? It's
Yeah.
Naveed.
Yeah, Naveed, go.
Thank you, Dr. Simon, for nice presentation. I fully agree that this is like a very good meta-analysis. So let me ask a question to Dr. Junaid. What was the primary outcome for CAP trial? They didn't compare the apnea like yes or no. They just compared the primary outcome was neurodevelopment. So
Yes,
that's why they removed the
was the
CAP trial.
hypothesis. Was the hypothesis that the caffeine, the hypothesis of this thing is the negative hypothesis that the caffeine can affect the neurodevelopment outcome. Okay, so this is the negative hypothesis. But when they found it out that the caffeine is excellent for the apnea of prematurity, then they make it as a primary outcome. Okay, and
No,
then they
their
find it
primary
out.
outcome was neurodevelopment. It was
Yes,
not quantified.
initially, but if you see that it's ready with the follow-up of the caffeine, and then they found it out that it is very good for the apnea. They make it as a primary outcome, and BPD and PDA they made it as a secondary outcome, and they will
No, the
match it.
CAP trial, if you see, although it is like caffeine for apnea of prematurity, but the
Yes.
primary outcome was not yes or no dichotomous. So CAP trial
No.
should not come in the apnea of yes or no. So always meta-analysis go by primary outcome, not by secondary or anything later. So you can see like the primary outcome they included in the other outcome, but not. That's why I'm saying there is a low certainty of evidence for apnea, and I fully agree. This is like I square is 78 because there is very low certainty that there is heterogeneity among the, and I'm quite surprised that people adopted this caffeine for apnea with such a low, like less than 400 total cohort of the study participant. So my reply to that is that the primary outcome of CAP trial was not to assess for apnea. It was for the neurodevelopment. That's why they didn't include the CAP trial.
Yeah, Naveed,
My
you are right.
impression is also the same as Dr. Naveed said. They actually did a lot of post hoc analysis, and that's how they came up with other ideas. I think the initial trial was designed for as a primary outcome being neurodevelopmental outcome. And
yes,
and you know, this is very interesting discussion. It's every day's discussion in every NICU, to be honest.
And they mentioned as well that there is quite heterogeneity. That's why they did include the CAP trial.
So Naveed and Safdar
Yes.
and Dr. Junaid and Dr. Sajad, may I just for a second? And I'll definitely will not take more than a minute. First of all, let me give you a full disclosure. We do 32 and under loading dose of caffeine, 20 milligram per kg. And we usually start with 5 milligram per kg of maintenance dose. And then based on an individual baby, to avoid going from CPAP to non-invasive ventilatory support, or if the kid is already on NIPPV, to avoid intubation and putting them on vent, we go up onto the dose of 7.5 and even up to 10. So let me give you an example. I have a 26-weeker admitted. I'll give a loading dose of 20 milligram per kg, put the kid on 5 milligram per kg and on CPAP. 3 days later, the nurse called me, multiple events. I'm going to increase the dose to 7.5 milligram per kg and see how the baby does, repeat the gas, yada, yada, yada. Again, kid is still having events. Before going to NIPPV, I'm going to go on to the higher dose and then maybe opt for the option of even going on NIPPV. But if my kid is already on NIPPV and I have to avoid intubation, I am willing to give another loading dose besides the higher maintenance dose. That's the first part. The second part is that myself, Junaid, and Naveed were having that fascinating discussion about the cumulative dose, which I'm going to stop here and I'm going to let Naveed explain what he had recently talked about in his unit. Thank you.
Naveed. Dr. Naveed there?
Yes, sir, Dr. Sajad.
Yes, please. You want to comment?
Actually, I'm on live, so I'm in and out, so
Okay,
I missed.
no worry.
So Naveed, the discussion that we are having about the cumulative dose, go ahead and tell them.
Yeah, so one thing like we say like in our most of the part, like if the baby has no apnea and we start caffeine, So we say that, oh, if it is not apnea, it is for the neurodevelopmental protection. But if you see, so far, there are only 2 trials done, and most of this data is by the CAP trial, because it was quite good trial, and they look at 2 years and 11 years outcome. Other trial included in this meta-analysis was by Shasha, and there was some risk of bias as well. But based on these just 2 trials, that's why they didn't include this one for the forest plot of neurodevelopment. So just recently, we noticed that someone talking about the cumulative caffeine dose, because they say, no, if we stop, it will have like effect on the brain. So that's why my question arises that, does caffeine affect its dose having a cumulative? So just recently, I just posted one article on the group that people are studying the cumulative dose of caffeine. Higher the cumulative dose, the better is the neurodevelopmental impairment. But obviously, it was an observational study with its own limitation. So we need more robust data in terms of RCT to be more sure about whether cumulative dose is important or no. Thank you.
So do you do serum levels of the caffeine?
No,
Does
we
anybody
don't
does?
do unless it is like a
It's all
tachycardia.
clinical. Yeah, so cumulative dose we calculate from whatever we are giving clinically.
Yes.
Yeah. Okay, that's
I
fine.
have a question beyond the
I think
discussion ongoing.
Dr. Naila Nizami was trying to ask a question. Is Naila here? Naila, you are here? I think she has left. Okay. Yes, please. Yes, please.
I have a question beyond the discussion we are doing already for study credibility heterogeneity. Dr. Junaid, you mentioned that you did a study about carbon dioxide. You did some studies and you found that it should be decided according to the sensitivity of carbon dioxide. How can we implicate that thought in our regular decision making about caffeine dose, high, low
Yeah,
doses?
that's my whole point with all these studies and meta-analysis. Any study you do, any study you read, it should be read critically and to see what is the clinical implications of that study. I'm not saying that the researchers did a thing, but the outcome of this study is not that we can, talk about clinically. Now, the point is, I am making it that the carbon dioxide sensitivity is different in different is gestational age and different gestational weight. And that sensitivity can be the key to increase the dose of caffeine. So for example, 24 weeker, 23 weeker, last week or week after, I have, many. And I started the same, like every one of us doing 5 milligram per kg after the loading dose, 5 milligram per kg. But the baby is not doing that great and they still have some apnea. So we increased the dose to 7.5 and sometimes 10. And it has its effect and will continue for a long period of a time up to the 34, 35 weeks. And then the baby outgrow the caffeine by his growing weight. That's how we are doing right now. And we found it out is still, it has its effect that the high dose is still has its effect. Yes, meta-analysis not showing, and it is of very low certainty. The other point I am telling to Naveed and, to Nasir and everyone, please read the caffeine of apnea, caffeine for apnea of prematurity trial. The major thing what they want to see is the 18 to 21 month or whatever it is, the long-term neurodevelopment outcome. But the short-term outcome is the apnea. That's their main also, that the short-term outcome, and with we started caffeine not for the long term. We are starting caffeine for the short term, that the baby, when he is ventilated or on CPAP, on NIPPV, they shouldn't have apnea. That's our whole point. So the reason for that the CAP trial is the hallmark trial that all of us started using caffeine And it is not at that time you did the history of caffeine before the people are using theophylline, aminophylline. It is there that the stimulant is very strongly reduce the apnea of prematurity in all those very tiny babies. So that's why people are, when the CAP trial come out, is starting and it is a standard of care. I don't think so. Any tertiary care, any level 4 nursery is there that they are not using caffeine. So that's how it is. So the carbon dioxide also, so that's why I'm saying that the carbon dioxide threshold is different. I cannot, I'm actually outside my office, outside the country actually. I'm in your country right now in Canada. But I'm just telling you that I have the graph where it shows that how much carbon dioxide different age group and the different gestational age is needed, and then what is their apnea threshold, which is different in different babies, different the adult and the full-term babies are totally different thing. But do you think that the full-term babies don't have the apnea? They can have the apnea for some different reason. So anyway, having said that, my point is that the high dose has its own clinical impact when it is needed. So to conclude that, of course, evidence can be the very low certainty. In neonatology, there are a lot of evidence which is low certainty we are doing right now. But the thing is that to conclude that or to give the message that these are the low certainty evidence and these are this thing. That's why every of these type of studies or the further studies needed. I give you one example. If you give 30 seconds, if you know the PLUS trial, there is a very hype of the PLUS trial, which is give the surfactant and budesonide and the corticosteroid at the time of the surfactant together, which called PLUS trial. It is a huge trial, very well, randomized control in Australia and the New Zealand. And the people are thinking, because initially small trials for this practice give a very positive result, but the people are thinking we will get and then we will not have the BPD by doing this. But this trial shows no effect, zero effect. So that's how it is. But they are not saying that this have a low certainty or this thing. So these type of trial, if you combine together, let's say the PLUS trial and the previous trials with the same practice of surfactant and steroid giving together at the time of intubation, that give you the meta-analysis. Maybe they give you the good, good answer, or maybe they give you a bad answer. That's fine. I'm not talking about their answer that it is low, but the message they try to give is not appropriate. That's my whole point. All meta-analysis can be, read very critically, and its clinical implication is very important. Do you want to change your clinical practice on depending on this meta-analysis? What Nasir asked you very rightly, you said no. This is first point we have to understand that. The second point we have to understand that meta-analysis are they did properly or not, because there are many meta-analysis. I can throw you a lot of articles, which is, if you see why they do that, why they do that meta-analysis, what is they
I
wanted
think,
to
Dr.
try.
Junaid, can I ask you a question? Does every meta-analysis have to change our practice?
As what?
Does every meta-analysis has to change our practice?
Not at all. That's why my whole point.
So that's fine then. I mean, if this meta-analysis is not changing our practice, it means whatever we are doing is right now okay based on the current evidence.
Okay. So
So
then
that does not disqualify the meta-analysis from
no.
reading or discussing or doing
See,
anything.
the
It is still worth.
disqualification of the meta-analysis, Dr. Sajjad, not is the result. How they do it. This is the thing. The method is the most important thing, and their methodology is not good. That's my whole point. If you read this thing, I read it before, and I think people know that there are a lot of loopholes in their methodology. So if you don't do see, if you would ask me how to go to from UK to Canada, I can take a direct flight. I can go all over the Europe, and then I will reach. Results is the same. I will reach Canada, but my method will be wrong. So that's how it is. The methodology I'm talking about, it has to be more appropriate for these type of studies.
Dr. Junaid, I think such kind of studies are more important than a systematic or meta-analysis which finds positive finding, because such studies tell us that what we have already clinically is efficient, it is enough. And secondly, about the methodology, I think it's more of like the people who publish it and then the process which it goes through, it's their responsibility and their like side that what was done and how was it done for but right now I think this is a very appropriate the meta-analysis for our discussion, because it tells us that high caffeine is like the best that we use currently is the best method for apnea of prematurity.
I think I agree with this, and also the caffeine is better for apnea than giving nothing.
Can I tell on a lighter mode how we practice? I had two practice experiences. So when I started back in Miami, we were loading at birth, and there was an interesting different kind of practice we were doing. Like, for example, if you're intubated and you are 24, 25 weeker, we will not start caffeine right at birth. Like, if you're intubated, we only will start when you are planning to extubate. So that was a little bit different variation in our practice. And also in Miami, we were mostly loading and then giving higher dose, like 10 per kg most of the time. The advantage was that we were not reloading, and the other advantage was we were not checking levels. In my new practice here, we start with 20 per kg. We start as maintenance 5 per kg, and then we end up loading in between whenever we need to load, especially when we are trying to extubate, we will reload again.
So Sardar, 1 minute, sorry. So why you reload?
Just because when people look at the data, especially they will reload if they are having events and they feel like, oh, maybe either we check the caffeine level, it might be subtherapeutic, or they will just load it instead of checking it.
No, they never check it. I make sure. I'm give you the 100% guarantee. They never check the level. They reload because there are some studies. That's why I'm saying this is not only the one study that is showing that the high dose can give a benefit to these type of the babies. That's how it is. So that's why they reload it. Like seizures are not controlling. You give phenobarb, you reload phenobarb. Similarly, like this, that sometimes the higher dose is beneficial for the babies of a different gestational age and gestational group.
Dr. Junaid, let me give you one more comment on it. There was a trial, I'm just forgetting the name of the trial. I'll probably look back and send it to you. There was a trial which was stopped. There was a group of people who were very overzealous. They wanted to give 80 per kg of caffeine and see if it will make a difference. So that 80 per kg, they have to stop the trial. There were so many side effects in that group, and they stopped the trial in between.
That was an Australian trial, I think.
Yeah, I'm forgetting the name. So I'm saying, like, we have to
Australian trial,
Dr. Syed, the point I'm making, we have to find a fine balance. And this is a good discussion, to be honest. I mean, I think a group discussion where we disagree is way more beneficial, where everybody agrees on one point. And that's why I like this whole discussion in the Journal Club, the way it has ended up.
And Sardar, just my last point. And
Yeah.
you have to have in the discussion one person who is against that study.
Absolutely.
Otherwise, there is no point of this discussion.
Absolutely. There is no point of everybody saying, hey, everything is hunky-dory. No, that's the whole point.
That's the whole point.
No, just my last point. I think Junaid, I give him credit, is that when he has a point, he stands by it. And having a dissenting opinion in any discussion is very important because all of us learn from each other. Thank you, Junaid. Thank you.
Thank you, Nasir.
Yeah.
So anyway, I
Nasir,
think
Nasir, Dr. Nasir, can I have a question, please?
Yes.
Dr. Sajid.
Please go ahead.
Actually, my car broke down and I'm at a workshop. So I was going home.
give caffeine.
So the my question is that apart from this research and study, there's a one common saying that if a solution is not affordable, that's not a solution. So the problem is that in Pakistan now caffeine is costing 2,800 rupees per vial. And when we start in these tiny babies, we have to take it longer. So my experience in 8-9 years is that either when we start, it's okay, but in the middle, we are really stuck because parents, they don't want to continue it because of the cost. Number two, if we are just switching them to the oral one and sending them in a room with the mother, room in, again, they say that we can't afford it, please stop it. And we don't have, like 10, 15 years back when I was in UK, we have apnea monitors and we put them on apnea monitors for 2-3 days and then we sent home. Now I am struggling. One is with the cost. Other is that these trials, they showed you have to give high dose and longer dose. That's another problem. So sustainability is the issue. So how to handle this complexity apart from this meta-analysis? I'm stuck with this. That's why my main fear is this, the cost effectiveness. Any suggestions for that, please? What shall I do? The other caffeine or this caffeine, 2,800?
Dr. Junaid, go ahead.
Sajid, just in a brief, just tell me again your question.
My question is that when we receive these tiny babies, we start caffeine when there's apnea, we start it, but because the one ampule costs 2,800 rupees nowadays, so 10 ampule box comes 28,000 rupees. And can you imagine if they have to pay for a ventilator or a CPAP or DUPAP? Like in my center, the almost less than 3% babies, they are going on ventilator. The rest of them, they are NIPPV, DUPAP. But the problem with the DUPAP or NIPPV is it sucks in so much oxygen, like 16, 17 liters to maintain the PEEP and maintain the PIP, because when you are going to give the PIP, the machine sucks in 16, 17 liters of oxygen. Let's say when the baby is on 30, 40%. So that's why in my hospital, I've got a liquid cryogenic oxygen. I do not have a complex oxygen. I cannot cope with this high demand. So they have to pay for the oxygen. They have to pay for the circuit. They have to pay for a cannula. Cannula is costing 520 rupees nowadays. And I've bought the cannula in a bulk, and that cost me almost 170 rupees. So that's why I charge from the patient 220 to 30. But outside in the pharmacy is 520, and surfactant has gone 30,000 rupees. So my question is about the cost. That it's not a surfactant that you give once. It's a caffeine, is a stuff which you have to start and you have to continue for longer duration. And we stuck in the middle because parents don't want to buy it, and then we have to spend from our own pocket. So sustainability is the issue. We stuck in the middle.
Yeah, you are right, Sajid. But the thing is that the oral caffeine, has a different price there or the same price in Pakistan?
No, we just use the very same injectable orally. We don't have we just give the very same.
Okay. So this is the thing. First of all, there is a oral caffeine out in the market, if you can try to procure. Second thing, I'm telling everyone since very beginning, me and Dr. Sajjad did a lot of workshop on non-invasive ventilation. If those premature babies are getting a very low cost, the mothers on antenatal steroid, when they deliver, okay, if you start nicely on the NIPPV or nasal CPAP, most of them do very well. So we have a problem that we cannot give caffeine like developed countries because of the cost. But at least we can take care of those babies on the non-invasive ventilation as much as is possible. Yes, they can have the apneas and this thing, then we have to do some, other thing. Sometimes people are still using the theophylline, and the theophylline is also has a very good result. Yes, this has the side effects of that, but if you see the initial studies, the theophylline is a very cheap. And yeah, if you have a problem with this, that the baby need to intubate, or get it in that condition that from non-invasive to invasive, then you can use the theophylline, which is still but you have to monitor more.
Actually, what I'm doing is that I think you could pick the right point. What I'm doing, I've told the parents, look, this is a medicine, it works. Research has proven that. Either I have to rely on a CPAP, DPAP, or a NIPPV, and most of the babies, even these apneas, they improve with the time. But if we give this medicine, this might work. If it works, but the cost is issue, and you cannot stop in the middle. So few families, when they say that we can't do it, and we have seen that even when we put them on NIPPV and DPAP, with the passage of time, the frequency, lessens and they improve. It's all, it's a judgment. So sometimes I get stuck because I think that if I start from caffeine, then they cannot afford, they don't have any money. So this is how the non-invasive ventilation is very helpful. That's my point.
Call you because I needed your help desperately. Thank you very much. And thank you everyone, Dr. Junaid, Dr. Naveed, Dr. Sajid. I forgot the name, Dr. Avranos, and everybody else who participated in the discussion, and Professor Haq. Thank you very much. So see you next month, inshallah.
Inshallah.
Thank you very much.
Thank you.
Assalamu alaikum to everyone. Assalamu alaikum.